meant like you ready for me. My bad. I'm bad at communicating that.
All good.
All right, so we are in our third installment of Catalyst Chat, and I'm so excited to present Dr. Matt McNeill, who's joining me today to talk about all things colon and gastroenterology. And it's very timely because it's Colon Cancer Awareness Month.
Correct. Colorectal Cancer Awareness Month.
Colorectal Cancer Awareness Month, and it's definitely been a newsworthy item recently with some high-profile celebrity deaths related to it. So we're definitely going to get into colon cancer. But let's start with you and your medical journey. So where did your medical journey begin?
So I'm proudly from North Carolina, went to Duke undergrad, and then went to UNC for medical school. And coming from a family of doctors, grandpa OBGYN, mom endocrine, and was really deciding what to do. And just remember sitting in the gastroenterology section of med school and thinking, wow, these guys really seem to be enjoying what they do. Not to say other doctors don't enjoy what they do. Obviously, you're not a gastroenterologist and you enjoy what you do, but they were really excited about what they were doing, both in terms of their day-to-day life procedures, but also like, we talk about poop and gas and sometimes the most intimate thing, eating, that people do every day, and enjoy doing that. And so that really stuck with me as then I went to NYU for residency, chief residency, stayed on for fellowship, and then graduated several years ago from that and joined a private practice, but still do faculty and consult time at NYU.
Cool. What's your fellowship training in?
In gastroenterology.
Oh, right, of course.
Yeah.
Okay. Duh. I think that I enjoy the medicine I do now. I don't know that deep in my ER shifts, I would say that I enjoyed that. But good days and bad days.
No job has all enjoyment, I would say.
Yeah. What is the craziest gastroenterology case that you saw during training?
I mean, the foreign body cases are always
I have some good ones
somewhat fun, which I'm sure you get in ER training as well.
Yeah.
Never insert anything that doesn't have a tapered end to it.
Yeah.
I definitely recommend. We've had glasses cases with glasses inside wrapped in electrical tape that somehow made its way inside of a husband of a woman. That was interesting.
Okay.
I've had, vibrating sex toys.
That's a dime a dozen.
That were actively vibrating, that were still inside someone that I've been called about before. Those are always the ones that stick in your brain most memorably.
My craziest rectal foreign body is a can of butane fuel.
Okay.
Yeah.
That's like a Grey's Anatomy episode.
Yeah,
you got to call like the fire department
it's
for
pretty
that.
wild. And he knew something was up there, but he didn't know what because he was intoxicated when it was put up there. Yeah. So
yikes.
Yeah. And what is one thing about the colon, the gut, that you've learned from your extensive years of training that common people do not know? That's like the number one thing you want to tell people about the colon.
I mean, well, just the GI tract in general. People are always focused on their nervous system. Like, I feel stressed, I feel anxious, I feel, tingly, I feel cold. Because your nervous system, your brain, your spinal cord, all your nerves that go everywhere, your muscle control, that's your largest nervous system. Well, your second largest nervous system is your enteric nervous system. That's the nervous system that controls your GI tract. A lot of that happens without your power. So, digestion, normal movement, and the pain and discomfort that can kind of come with that. So if things that affect your overall nervous system also can affect your enteric nervous system, and you see that in both the symptoms like bloating, constipation, gas, pain, diarrhea. And so I think keeping that in mind when you're managing and evaluating some of the symptoms that are GI symptoms is also very important.
Yeah, it's interesting you say that. I know that things like anxiety and depression are strongly correlated with stomach symptoms. Mm-hmm. I know a pediatric gastroenterologist who, as part of his peds fellowship, they make them do like psychiatry rotations because they have to learn a lot about mental health, because pediatric abdominal pain, like kids with abdominal pain, so much of it is related to anxiety and stress and depression. I thought that was interesting that that's like required as part of their training so that they can understand that connection.
Yeah. And I mean, I would say especially we're seeing in younger populations higher rates of prescription drugs for mental health issues, whether it's SSRIs or anxiety medications or things like that, which can have positive and also negative effects on the GI tract.
Yeah.
But taking into account mental health and the different ways we treat mental health, which doesn't always have to be medications,
Right.
really does also affect how we have learned how to treat IBS, functional pain, and things along those lines.
And we'll get to IBS
Yeah.
shortly. So walk us through the journey through the GI tract. Like
Okay.
What are the components of our gut?
So the luminal, meaning the tubes, is the plumbing, is kind of the first part. So you have your mouth that leads to your esophagus. Esophagus' real role is just to get food from the mouth into the stomach in a controlled fashion. Now, people have disorders there, but that's probably not the biggest one we want to focus on, although I do focus on that one. Into the stomach, which is where a large of the initial breakdown of food and digestion occurs. The most important part of the tubing is the small intestine. You can live without your esophagus. You can live without your stomach. You can live without your colon, also known as the large intestine. But the small intestine is where you get nutrient absorption, where you get liquid absorption, where you get a lot of the breakdown of food. And if you don't have that, then it's not compatible with life. Once you get past the 20 plus feet of the largest surface area, which is the small intestine, into the colon is where a lot of the stool is concentrated. Really, the water comes out of it, and it's really, really formed before it gets down to your rectum. But I don't want to sell short the rectum, because the sphincter, you have a lot of sphincters in those tubes, but the sphincter, the anus, one of the more important ones there, and if you have any disruption there, that can really lead to some serious issues down the road.
And sphincter, for people who don't know, is like thick.
It's an opening between. It's like a valve kind of.
Yeah.
It's an opening between two things that can open or close. You have a few of them. You have one between your mouth and your esophagus, one between your esophagus and your stomach, one between your stomach and your small bowel, and then finally one also that kind of goes between your anus, your rectum.
Yeah. Okay, so let's zoom in on some components of the gut, or of that luminal digestive tract that you described. And I'm always approaching from a functional health perspective. So in the esophagus, I feel that in medical school, when I learned about gastroenterology, that eosinophilic esophagitis was like one slide in one day of a deck of like 70 slides. And yet, anecdotally, from working in the emergency department now as a functional health doctor, I am seeing so many cases of it. So I think it's really interesting. It's not something that common folk have really heard of as a disease, but it's fairly prevalent. And it can cause chronic symptoms in people, and they just don't really understand what's happening because it's just not such a well-known phenomenon. So I was wondering if you could describe that disease a little bit.
Eosinophilic esophagitis, which we abbreviate as EOE.
Yeah.
It's an allergic type esophagitis. Esophagitis meaning just inflammation of the esophagus. It typically occurs in men, actually. It's about 10-to-1 ratio in men, which is interesting because it's one of the few autoimmune diseases that occurs in men more than women or ATP
Do we
related.
know why that is or no?
I'm not sure, to be honest with you.
Me neither.
And the way it typically presents, so an eosinophil is a white blood cell that is usually associated with allergies, so asthma, parasites, and then eosinophilic esophagitis, allergic reactions. So you get this inflammation of eosinophils in the lining of the esophagus, which impairs the esophagus' ability to kind of do its natural squeezing or peristalsis of food down from the mouth into the stomach. And so when you eat certain foods, normally the foods that don't just readily break down. So you think of like crusty breads or meats or, broccoli, things like that. Those are the foods that tend to get stuck in the esophagus in someone who has EOE because they just don't move readily down the esophagus. A common misconception, those are not the foods that are causing the inflammation. Those are just the foods that get stuck.
Okay.
The foods that typically cause the inflammation are our common allergens. So you think of gluten, dairy, eggs, soy, tree nuts, and shellfish are the primary drivers. Now, EOE has really come into the medical consciousness in about the last 20 years or so. It has existed for a while, but as we've kind of moved toward clean culture, much like asthma, much like inflammatory bowel disease, we've seen this rise in these certain allergen-driven or autoimmune conditions. It's certainly increasing in more developed countries that have higher hygiene standards, which is some of the thought process behind EOE. Fortunately, we have a lot of good treatments for EOE. Also, fortunately, EOE doesn't affect your life expectancy.
Yeah, it's benign, but it can make your life...
it's an inconvenience, but it's an inconvenience that's treatable. And so if you're having issues with swallowing, definitely recommended to get evaluated for it, because you never want to get the food stuck in your esophagus when you're traveling in some remote jungle and then be really in a bad spot.
Couple follow-up questions. So is the main first line treatment is avoiding the offensive agents like the food triggers, and then are there prescription treatments?
So yes and no. There is something that is an elimination diet where you have to sequentially remove certain foods. That is a little bit laborious, and most patients don't, one, like doing it, and two, don't often find that they have success in finding necessarily what the trigger food is. So generally we move to the first line therapy, which is some sort of acid suppressing medication, a proton pump inhibitor, your common ones being omeprazole or esomeprazole. If patients respond to that, which most do, but if they respond to that, we talk about how to titrate that down to a sustainable dose where they're asymptomatic. Those who don't respond are those who have severe inflammation. And inflammation could be so bad that you are down to a pinhole. I've had patients who literally are on full-on liquid diets, and I can't even get the scope down to their stomach because their inflammation is so severe. There are biologic medications, the biggest one being the brand name being Dupixent. It's the only one that it's in existence for. That's also used for asthma, eczema, nasal polyps. And that's about 100% effective for UE. It's a weekly injection though, but it works amazing. And although I've had patients who are hesitant to start it, I've never had a patient not come back to me and be like, this is a game changer for me.
Okay, cool. I'm going to keep moving down the track. So let's talk very briefly about GERD or gastric reflux, which is obviously a huge topic, but I feel that people kind of understand what it is and patients understand the symptoms of it and the triggers of it. I have a question for you. Mm-hmm. If someone gets an endoscopy that shows signs of reflux, but they're not having physical symptoms, what do you do with that?
Okay, so an endoscopy does not diagnose reflux, which you are alluding to, right? You know, it's not the gold standard for reflux. It can show signs of reflux like esophagitis, which is probably the major
inflammation
of the wall of the esophagus, usually like ulceration. That's probably the primary driver, the primary symptom that we see on endoscopy. It can show things that predispose people to reflux, like a hiatal hernia where the stomach comes up into the chest cavity a little bit, or they may have a looser lower esophageal sphincter that we see on the endoscopy. If someone is asymptomatic, well, first question would be, why am I doing the endoscopy in the first place? Because usually there's a reason for doing it. But if I find it for another reason, and we see that in there, I usually do recommend some sort of treatment, because the reason we care about managing GERD.
Next question.
Yeah, well, the reason we care about managing GERD, number one, because we're always patient focused here, is I don't want you having symptoms.
Yeah.
I don't want you having symptoms. I don't want you feeling like you can't eat spicy food and acidic food. I don't want you waking up in the middle of the night with a burning in your chest. I don't want you avoiding certain foods. I don't want you having symptoms. It's not fun. The second reason is because chronic inflammation anywhere in the body leads to cellular change. Okay, you think of smoking leading to lung cancer. You think of sun damage leading to skin cancer. You think of HPV leading to cervical cancer. Chronic esophageal inflammation, chronic esophagitis, is one of the primary drivers of esophageal cancer. Yep. Now, it's not something that happens in a year. It is a often decades-long thing. But we know that, especially in someone who's not having symptoms, that could be a theoretical problem. So I definitely would treat it. Definitely have a conversation about what their diet looks like, what their behaviors are like, and then discuss, depending on the severity of it, what our surveillance or monitoring is going to be like.
Yeah, that's really helpful. That was the point I wanted to drive home, because I don't think too many people understand that it is a cause of esophageal cancer, a contributor. And esophageal cancer is one of the more gnarly types of cancers that I've seen in my experience from the emergency departments and ICUs. It's not a cancer that you want to get.
No, it's definitely not. And, you know, we probably are not seeing it as much as we used to. I mean, you think of typically 60, 70-year-old men smokers and drinkers are the two biggest groups. Smoking rates are way down nowadays, as I'm sure we'll allude to in a lot. Drinking still happens out, but obesity is still a big cause of chronic reflux, which we know those rates are going up. Yeah. And so who knows if that's going to be now the new problem when it comes to reflux leading to esophageal cancer.
Yeah. You brought up a good point of something I wanted to highlight, which is, you know, I'm so many years out of medical school and now more years out of training. When I remember when I was a more junior doctor, my friends at like dinner parties would always ask me, what is a thing you learned in medical school that's so surprising to you? The thing I would always say is that I always thought smoking just caused lung cancer. Oh. And smoking causes so many diseases of the gastrointestinal tract. Yep. And we don't associate it with that because we don't think the actual smoke gets there the way it gets to our lungs. but smoking causes cancers of all the mucosa of your face, your throat, your esophagus, stomach,
colon cancer.
So
Yeah.
it really, when you see people smoking, it's crazy how much cancer it can cause and does cause.
When I'm doing my intake questions in every patient, I say, well, do you smoke? Which most of my patients say no, but the ones who still smoke cigarettes, I say, well, when are you stopping?
Yeah.
Because honestly, that is number one thing you can do for your health is to stop smoking.
Definitely.
And, vaping's only been around for a few years, and it certainly doesn't have the same tar exposure that smoking does, but I think the jury's still out on how that may be affecting cancer risk in other areas of the body. And I don't think it's probably the same, but it's probably not negligible.
I'm definitely curious to see some of that data when we hit 10 to 20 years.
Yeah.
Have you seen anything linking like vaping to gut health disease?
Those who are really aggressive vapors, I do find that it can affect both IBS symptoms sometimes.
Okay, that makes sense.
There's not been data on that, but I do tie it. It feels like and definitely when people stop vaping anecdotally, they feel a lot better when it comes to
it makes
health.
sense intellectually, mechanistically. Okay. Let's move to the stomach and let's move to the gastric outlet, which is the part of our stomach that empties into the next part of the gut. I want to get your hot gastroenterologist take on GLP-1s. And I know that's like a big question, but I want to know from the gastroenterology perspective, because for people who don't realize, they slow down stomach emptying, which can cause things like obstruction of your stomach, which is when you can't push gas and poop through the colon as well.
Yeah.
So I want to know.
So full disclosure, I prescribe GLP-1s. I have friends and family on GLP-1s, and I think they're a really, really amazing medication for the right patient in the right setting. And so, GLP-1s work in 4 different mechanisms, and we didn't talk about the non-luminal parts of the GI tract, but they increase insulin from the pancreas. They decrease glucagon, which prevents fat storage and helps burn fat. They suppress the internal hunger drive, and then they slow the GI tract down. Now, we really focus on the stomach part of this, but they actually have effect on the entire GI tract, because when we think of the biggest GI side effects of GLP-1s from a stomach perspective, reflux and nausea, especially in the day 2 or 3 after people get their dose, and then constipation being the other one. Gastroparesis, which is the medical term for the delayed gastric emptying, a lot of things can cause that. You're basically using medically induced gastroparesis to prolong hunger, and prevent people from eating as much. And that's one of the ways that GLP-1s work to help people lose weight. It is really important for people to find the right dosing and how to take it appropriately when they're working with their doctors on GLP-1s. Because if you are eating through it, you're going to be sick and have super symptoms and either stop it abruptly or just not be successful for it. Or if you're having symptoms, it's important to talk to your doctor about what options are. And I tell patients, look, 1, smaller, more frequent meals, so that you're not getting as full as quickly. 2, holistic things are really good. Ginger candies, ginger chews. I like peppermint oils. And then if we really need to start talking about, other medicines, there are prescription strength medications for nausea if that's and reflux if we need to. The only downside of that is you might be counteracting some of the benefits that you're trying to get from the GLP-1s if you're prescribing those.
I think the answer lies mainly, if you can, in what you described as you have to find the dose that's right for you. And most of the issues with intestinal blockages are because people are on too high of a dose for them. And it might be that at a lower dose, you have a little bit of satiety, like fullness, and a little bit of indigestion, but you're not fully blocking like the passage. So you have to find that balance. Okay, so let's move into small bowel. And then we'll hit colon, we'll do colon cancer, inflammatory diseases. But in small bowel, I did want to get your take on SIBO, small intestinal bacterial overgrowth, because from the functional health perspective, you have a lot of people coming to me, saying, I've gotten these $1 million GI workups, normal colonoscopy, normal endoscopy. It wasn't until I did a breath test and I found that I have too much SIBO, and that solved all my issues. But I want to get your take on it because I know that it's a controversial disease.
SIBO is very controversial. Part of the reason it's controversial is there are no single gastroenterology guideline that exists on diagnosis or treatment of SIBO.
And why is that?
Partially because it's probably hard to test for. It's probably hard to test for. And also majority of commercial labs don't
test
offer
for it.
SIBO testing.
Yeah.
Okay. Now, that's not to say there's not a lot of research being done on it. It's not to say that they don't talk about it at conferences. It's definitely not to say that I don't diagnose it in treatment, because I do it all the time. But that being said, it's certainly a very nebulous area. And what SIBO is, small intestinal bacterial overgrowth, is you get a overgrowth of certain types of bacteria that, when traditionally exposed to carbohydrates, tend to overproduce gas. And so the number one presenting complaint with a SIBO diagnosis is bloating. And I have patients, male and female, come to me and say, I feel and look pregnant after I eat. And when I hear that tagline, I'm like, oh man, immediately thinking SIBO. But bloating is not the only symptom that people get with SIBO. You also get brain fog very frequently. You often get, especially with certain types of SIBO, loose stools or diarrhea. You can get constipation, specifically with methane or intestinal methanogen overgrowth SIBO. And there are certain things that certainly predispose people to SIBO. We think of like neurologic conditions, so things that might slow the GI tract down, MS, sometimes Parkinson's, sedentary lifestyle, certainly prolonged antibiotic exposure can really alter the microbiome in a way and kind of lead to the overgrowth of those certain ones that can lead to SIBO. One of my concerns about GLP-1s is that, are they kind of maybe creating a sort of environment that we may be seeing more SIBO with people on GLP-1 just because you're slowing the intestinal tract down,
which allows bacteria to overgrow? And
theoretically, yes. I mean, and as I was saying, one of the challenges is testing for SIBO. So there are tests for SIBO. They're not perfect. They take 2 hours long. They involve you drinking a carbohydrate-rich substance and blowing into a series of air or bad breath collection devices and mailing it to the lab, with the lab analyzing it for changes in gas production in response to this carbohydrate load. And when they're diagnosed, I will say, and I will send the test. I will say, look, this is the antibiotic course. To be frank, I never even was allowed to send a SIBO test until I graduated from fellowship, because it's one of those things where when you're going through training, unless people have amazing insurance or they're willing to pay for the test, which the test can sometimes be up to expensive, like $300+ out of pocket, you're just not sending the test. And so you're either kind of like working under a guessed diagnosis where you're empirically treating people with antibiotics, which has its own risks, or you're kind of like hoping that they can do the test and so on and so forth. So, but I certainly am diagnosing SIBO many times a week at this point. I have people coming to ask me about SIBO all the time. And there's a lot of overlap with IBS, functional dyspepsia, with SIBO. And so I think it's important to like talk about patients and how we treat those things in when you're talking in conjunction with treating SIBO.
For sure. Yeah. And I think my understanding is that a lot of times the tests can have false negatives, meaning you have SIBO, but the test won't pick it up because it's just not a perfectly accurate test. Correct. And so when you have a test like that, that's also expensive and not covered by insurance, you, as a doctor and as a American Academy of Gastroenterology, you question what is the utility here if we really are just going off of our hunch and ordering the test, just go off the hunch and diagnosing and treating. But like you said, then we're perhaps putting too many people on antibiotic treatment. If
you read the instructions that come with the test, patients are like, oh my God, I can't be on laxatives for this many weeks. I can't be on proton pump inhibitors because like omeprazole and Nexium, they can cause it for so many weeks. And it's measuring. The reason the test is timed over 2 hours is because the thought process is, as the carbohydrate load hits different areas of the small intestine, is gas being produced. Well, if you're on a GLP-1 and everything is slowed down, who knows about the validity of the test? I don't know how fast the carbohydrate load is going through your small intestine. Right. So you're exactly right. Like it's hard to ask patients to do that. So one of the antibiotics, which is used for the two primary types of SIBO, hydrogen and hydrogen sulfide, is actually in the algorithm of treatment for IBS diarrheal type. Which antibiotic? Rifaximin or Xifaxan. Not a inexpensive antibiotic if it's not covered by insurance. But it is only FDA approved for IBSD. There is actually no medication that is approved for SIBO by the FDA. So everything we're treating is kind of off book but if you have overlap symptoms, sometimes I'll have a conversation about, are we going to treat your IBS-D with the assumption that we may be treating SIBO in the process if we're going to go down that route.
Okay. All right. That was a really helpful overview. And you've mentioned IBS a few times in the discussion of SIBO. So again, this is something we could talk about for hours.
Sure.
But I think let's do a high level first summary of what is IBS. What are the main types?
Okay. So first off, IBS is not just a diagnosis of exclusion after we rule out everything else. Some people feel like it's a catch-all. No, it's a real condition. It's recognized by the medical societies. So when we think of IBS, so there's three primary types. There's IBS-D, which is diarrheal predominant. There's IBS-C, which is constipation predominant. And then there's IBS-M, which is mixed, which is some combination of diarrhea and constipation.
Yeah, and the constipation one's interesting. I think a lot of people don't know that. People, I think, assume that IBS is diarrhea, who don't take care of people with IBS. But constipation is one of the main phenotypes of it.
Right.
Yeah.
And the workup for it is very different. And the treatment of it is very different, but it's important that we get that context, which the big driver that kind of unites all these is pain and discomfort. So, when someone has pain or discomfort associated with a change in their bowel habits for a certain period of time, and then that pain or discomfort is either caused by or relieved by having a bowel movement, then that kind of meets the criteria for IBS. Yes, it is important to evaluate for other causes of diseases and symptoms that can cause these similar symptoms, but with IBS, you're looking at a lot of different causes in terms of the etiology of it. So, for example, what I usually tell patients with IBS is I say it's a multifactorial disease. It's what you eat, it's how you eat, it's how your brain is interacting with your gut, it's your microbiome, it's stress, it's anxiety, it could be some contribution from your medication, and it's all those things kind of boiled into one. And because of that, there's not necessarily a silver bullet treatment that works for one person, because you could have 4 or 5 different causes and it might be 10% this and 20% and 30% that. So it's a lot of tailoring different treatments to figure out what works for each individual person in order treating their IBS.
Mm-hmm. Okay. All right. That was a really helpful breakdown. Let's move on to colon and colon cancer.
Sure.
So it's Colon Cancer Prevention Month, or
Awareness Month.
It's Colon Cancer Awareness Month. There have been some very high-profile deaths in relatively young people.
Yep.
There's been a number of relatively young actors that have passed away in the last 5 years. The screening age for colon cancer has become a younger age because the incidence is going up in younger people. So this is something that patients are really curious about and asking me a lot of questions about. And I want to really understand what the data suggests and obviously counsel people on how to best prevent getting this disease.
Yeah.
So let's talk about overview. Is colon cancer becoming more prevalent and why?
So the answer is yes and no. Okay. On a global all-age population, colon cancer is decreasing. Okay. And by that, I mean above age 50, we are doing a great job screening people, and we are seeing decreasing rates.
So that is because we're eliminating precancerous polyps better before they turn into
That
cancer.
is one thought. The guidance until about 6 years ago, the guidance was to start screening above age 50. And then because of what I'm about to talk about, they lowered the screening age to 45 about 6 years ago. So we are colon cancer historically has been thought of as the disease of age, like many cancers. The longer you live, the more likely you are to get it. And to this date, about 89% of colon cancer is above age 50. So about 11% is below age 50. That being said, colon cancer is increasing in that age group below age 50. And it's been increasing in that age group below age 50 about 3% a year for the last 20, 30 years.
Lot.
Which is a lot. I mean, 3% of a small number,
right.
but still increasing.
One of the only types of cancers that's increasing in incidence.
It is one of the only ones that's type. So in above age 50, colon cancer is now the third most commonly diagnosed cancer. Okay. So in women, it would be breast, lung, colon, and in men, it's prostate, lung, colon. Okay. But is the number 2 cause of cancer death after lung cancer.
Yes.
However, the newest data that had just come out. And below age 50, colon cancer is now the number one cause of cancer death.
That was recent news.
Yeah, it's recent news. It just replaced breast cancer as now the number one cause of cancer death below age 50, which is obviously very concerning. You mentioned people like Chadwick Boseman, James Vanderbeek, obviously Catherine O'Hara. She died from complications of colon cancer. So yeah, it's concerning across the board, and I'm getting lots of friends messaging me, family messaging me, and a lot of very concerned patients who are like, "Why is this happening? What can we do about it?" And of course, like the GI societies are trying to figure out how to address it, because we see the numbers. They're doing lots of research on these numbers, and there's a lot of ways we can evaluate, screen, look for patients, but it's a little bit of balancing resources, evidence-based medicine, and then what the data shows.
Yeah, like medicine, and unfortunately, the traditional healthcare system can't take an individualized approach, because if every person went to go get a colonoscopy, we wouldn't have enough gastroenterologists, we wouldn't have enough OR suites to do the procedure, we wouldn't have enough anesthesia medicine. So we have to set a guideline based on the best literature, but that doesn't mean that it's the right approach for each individual based on risk factors and other components. What is your best guess, if you could make one, of why the incidence is increasing?
So like, if you read all the articles, they'll say, we don't really know. We don't really know, which is why we're making guesses. And it's probably a few different factors. Some of this is thought to be changes in the microbiome, which, we have much more significant antibiotic exposure. We also have a more hygienic culture, which doesn't always come with positives, even though we think it does. It doesn't always come with positives. There's also concern for exposure to processed foods and microplastics, and how those kind of like microcarcinogens over chronic time, especially on the mucosal surface of your GI tract, can lead to cancer exposure. Tobacco use historically has been a big driver of colon cancer, and that's way down. So we know that's great. Alcohol is, where it always has been. It's probably coming down a little bit, but I think those first two are probably what we think is the biggest drivers of this point.
Okay. Yeah, the processed food one interests me for sure, because I'm, as a functional health doctor, I mean, processed foods are very bad for us.
Yeah.
The Western diet has become incredibly processed. This is one of the really small little places of overlap where I agree with the current health administration about eating whole natural foods and avoiding store-bought products that have so many additives in them that our bodies did not evolve to be able to for our guts to digest these. So I'm definitely feel that the component of our cultural diet must be playing a role. I mean, who knows to what percentage? And we know that certain types of gastrointestinal cancers do cluster around cultures. Like I know that in the Far East in Asia, there is higher incidence of stomach cancer, correct? And it's thought to be at least partially related to the component of their diets.
There's some salted salted and pickled food related to the gastric cancer, but also higher rates of a bacteria, Helicobacter pylori, H. pylori, in East Asia and Latin America. Though the combination of those two things is thought to be the primary driver behind the increased gastric cancer rates in those.
So we have some kind of evidence that things can cluster around our culture, and who knows what's coming first. Like it could be the bacterial infections driving it. It could be the processed foods or the component of the diet. But it does seem like there's something that has shifted recently where the age is shifting backwards about, incidence.
Right.
So I think a lot of people are coming to me and asking, what can I do to prevent colon cancer?
Right. So when I get asked this question, I say, we're still figuring out the data. I don't know how much removing processed food from your diet is going to incrementally affect your risk of colon cancer. I don't know how much only taking antibiotics when you have a proven diagnosis is going to incrementally affect. I don't know how much taking probiotics is going to help. I do know that stopping smoking cigarettes would help. I don't know how much stopping drinking would help, and I'm still drink myself. So I say, yes, modify those things the best you can. But at the end of the day, colon cancer is extraordinarily preventable and treatable if caught early or prevented early. And so the number one piece of advice I tell people is make sure you're up to date with your screening. And if it's right for you, consider getting screened earlier than even what the guidelines may say. You know, because that is the number one thing you can do. Prevent it early, catch it early, and look for any concerning signs.
Yeah. Okay, that makes sense. I counsel people a lot on fiber because while I don't know if, and you can tell me if there's really good like clinical high quality data suggesting that fiber intake, you know, alters colon cancer incidence. It's a very hard thing to study, so I don't know. But I think mechanistically, we have pretty good data to understand that fiber increases the colonic transit. It allows things to pass more quickly. And that when things pass more slowly through your GI tract, it's worse for the development of colon cancer because bacteria can overgrow, cancerous cells don't get cleared as well as they normally would. That's my understanding. And so I do counsel people on a higher fiber diet because a lot of people don't eat enough fiber. Yeah.
All those things are absolutely correct. I mean, fiber is also great for glycemic control, cardiovascular health, you know, dyslipidemia, all those type of things. I always joke about if it didn't clog the pipes, we should put fiber in the water. Kind of like a cardiologist thinks I should put statins in the water. You know, I am a big proponent of supplemental fiber, not just high fiber diet, for the reason that you kind of alluded to, which is like you can tell someone to start adding fiber to their diet. Our diets are so inconsistent for the most of us, and so you know, you take those few fiber capsules in the morning, or you take a scoop of the fiber, and that way you know you're getting your dedicated fiber every single day. You know, is the way I would usually approach it with patients. As it pertains to the colon cancer risk, you know, certainly there is signal and noise that it probably is helpful, but it's at the margins. It's at the margins, but like even doing that at the margins is important though. If it's the difference between getting diagnosed with it or forming polyps or not, you know. The other thing that I don't want to discredit is talk to your family. Get your family history, and not just family history of colon cancer. Talk to your parents, talk to your siblings. Did you have polyps? Like polyp forming syndromes run in families. And you know, there are guidelines in place about if someone has a lot of polyps, if someone has large polyps, about when their siblings, their children, their parents should start getting screening or getting evaluated for polyps. And it might not be other versions of screening. It might be you should have a colonoscopy, not other types of testing, which we can talk about if we want.
So if I had a mother with a polyp, but it was precancerous, but it wasn't cancerous, would that change my starting age of colonoscopy
So
screening?
it depends on the polyp. This is where it gets a little bit. This is where it gets a little bit into the weeds. Well, how big is the big thing? Because a larger, you know, there's larger than a centimeter might be is considered more high risk.
So it's about size of it.
Yeah, it's a little bit about size and a little bit about the pathology. There's different types of pathology, adenoma being one, but also if there's low-grade dysplasia, high-grade dysplasia, among other things.
Okay, so you have to really get into the medical records, and
it's a little bit like playing detective sometimes when people come to me and say, "Oh, my mom had polyps," and I'm like, "Well, did the doctor tell her to come back in 3 years?" Which would suggest it was high risk, or there was a certain number that were higher than we would like, or did the doctor tell her to come back in 7 years, which may be less risky? And so like those are kind of the questions that sometimes the GI can tease out that you may not be aware of.
Okay. And there's Lynch syndrome. So there are syndromes that are associated with colon cancer, but colon cancer is basically it's a genetic inherited disease where you're more predisposed to many different things, many different types of cancers. And so what could happen is there could be other members of your family with other types of cancers, but you all have Lynch syndrome, and it predisposes you, and you're the first one caught with the colon cancer, right? So that's another reason, just in the bucket of make sure you talk to your family and you understand the things that your family suffers from, and report that to a doctor so that they can make the connection.
If you have a really significant history of cancers in your family, now cancer is 1,000 different diseases, but as you said, there are some that do run together. Specifically, you know, your ovarian cancers, your cervical cancers, your uterine cancers, your pancreatic cancers, like those type. You know, if you have a significant family history, both in grandparents, aunts, uncles, your parents, talk to your doctor about that, because that may, and talk to your family about that to see, have we seen a genetic counselor? Is like, do you know if anything came up when this was biopsied in terms of like high risk syndromes? Because certainly that can change when we start colonoscopy, because then we're talking like age 25 every single year.
And
you know?
And some people want to know, is cancer genetic? And a lot of cancers are not genetic that we know of, but there are certain clusters of cancers that do follow along genetic mutations. And so it's a mix. It kind of depends, and it's all about taking the right history.
Right. But the majority of cancers are not genetic.
Right.
So,
okay. All right. I mean, that was a good breakdown about colon cancer. I know that I have a lot of people coming to me being like, when should I get my first colonoscopy? And the guidelines are really clear that if you don't have risk factors, it's 45. And then I know that if you do have a direct family member who had it at below a certain age threshold, you do it around that time or 5 years before that time. Can you remind us?
So the guidance for asymptomatic, no family history is 45. Now, as I said, I have people who are coming and asking about doing it earlier for one reason or another, and that's an individual risk discussion, both in terms of other symptoms, insurance, among other things. If you have a family history of colon cancer or a high-risk polyp, now in a first-degree relative, first degree meaning parent, sibling, child, then the guidance is age 40 or 10 years younger than they were diagnosed.
10 years, okay.
With a colonoscopy. Only with a colonoscopy.
Okay.
No stool testing, no blood testing, no CT scans, just colonoscopy.
So if they had cancer at 38, which is
28
very rare,
for you,
then you start at 28.
Yeah.
Okay. Cool.
Yeah.
What have we not covered?
Well, we didn't talk about. I've kind of talked about the different screening but there are other, because I get a lot of questions about stool tests for first colonoscopy.
Let's talk about that.
Yeah,
because I had patients asking me to mail them the stool kits.
There's certain things that people need to know what those are. There's the blood test out, the Shield test.
And the Gallery test.
Yeah. Well, the cancer one is a little bit. That's a little bit, because that's like a private lab, so that one's a little,
Got it.
Yeah, I know the one that like looks for all the different cancer markers.
Yeah,
let's not touch one, because that one's still very that's not going to be on boards, because no one even knows how to touch that.
That's definitely not going to be on your boards. Okay, so but let's talk about the stool testing. Yeah.
So when we're talking about colon cancer screening, people generally think of colonoscopy, which is considered the gold standard because it allows for direct visualization of the colon. So if you have polyps, which in age, appropriate men, we find about 1/3 of the time, we can remove them, which is the preventative part of preventing colon cancer. Also allows for direct visualization. So if there is colon cancer, we're very, very, very likely to see it. But not everyone wants a colonoscopy, and there are other ways to screen for colon cancer. But they're not all the same. And I think it's important to know that before you go into it. So there's a few stool tests that exist. One is something called a FIT, fecal immunohistochemical test. That literally is looking for just blood in the stool.
LabCorp sells these like direct to consumer for like $60.
They're cheap.
Yeah.
They're easy to do. You can mail it in an envelope, and it's a 2-step test. So if it's positive, it could be a hemorrhoid.
Anything that causes
could be anything causes bleeding.
Yeah.
It generally
could be an ulcer.
Could be an ulcer. Generally, it's just recommended to have a colonoscopy.
Right.
It's not preventative if it's negative. It's certainly not an infallible test if there's not blood in the stool. So, and it's something that if you're doing it as a screening test, is supposed to be repeated every single year. It's not every 10 years, not every 5, it's every single year. So I tend to reach for that in younger patients who either because of insurance or because of other reasons are hesitant about undergoing a colonoscopy, or just because this is a good kind of like intermediate measure where we can say, hey, we're doing stool testing. There's no blood in the stool. If we have concerns, we can repeat it again. Now, mind you, no family history and not having symptoms. That's very important. Right. The other stool test that exists is the Cologuard. It's branded. That's a test that is mailed to you. It's looking for blood, so it has a FIT test component, but it's also looking for abnormal DNA in the stool, so hypermethylated DNA, which is often found in cancer, but also in large polyps. And that really is only approved if you're above 45. That is really only for screening age, and insurance will only cover it if you're above screening age. So it's not something I readily order on people, and frankly, if someone's willing at all to have a colonoscopy, it is recommended to do the colonoscopy at that point. Yeah. When the Cologuard comes back positive, once again, doesn't mean you have colon cancer. About 4% of people with positive Cologuard have colon cancer. We have to move forward with the colonoscopy. Right. It's also not an infallible test. Yeah. You're supposed to repeat it every 3 years. There are other ways to screen for colon cancer. There's a specific type of CAT scan or imaging CT scan that can be done you still have to drink the entire bowel prep to undergo that. And if they find anything, you have to do
get
it
a
all again and do a colonoscopy.
Yeah.
So it's like a lot of people, we don't really do that one very often. And then newly out, there's a blood test. And people are like, oh, blood test, great. I get my blood drawn, every 3 months, every 6 months. Like, why not just throw in a blood test for this? Well, one, it's not inexpensive. Two, while it is pretty good at detecting cancer, it's very bad at detecting any sort of polyps. So it's, when we think of it, it's more of a detection, not a prevention type test. And so
you're getting at a late stage of the disease already.
Right. So it's generally only recommended for those who are not candidates for endoscopic procedure, like for not candidates for colonoscopy.
Okay. And a lot of times it's people who like can't get anesthesia, can't do the prep.
Heart failure,
medically complex.
I guess theoretically, if you were pregnant and you just wanted to get screened, those type of things, but other reasons why you couldn't have a procedure easily, or it would be medically complex to do.
Right. Okay, cool. I think that was a really good overview of colon cancer, where we're at with the incidence, why we think maybe it's going up in incidence in young people, how to best prevent it from what we know. Definitely not smoking.
Yeah.
Is the main thing. What, as we conclude, because we're coming up on the end of time, are there any things that you wish people knew about the gut, that people are coming into you weekly and you're counseling people on things and you're like, I wish I could just explain this to everyone in mass?
Sure. Before we get to that also, I think it's important that you are in touch with your gut and your symptoms on a day-to-day basis, because I think we were alluding to, colon cancer screening. What can you do to be aware of it? The symptoms of colon cancer, I think, are important to look out for.
Yeah.
So, the biggest symptom in young people is rectal bleeding. Okay. And if you come into me and you're having rectal bleeding, that doesn't mean you're getting a colonoscopy. It means we're going to talk about why you're having rectal bleeding.
Right.
And so if it's because you're constipated and you're not having enough fiber and you have a hemorrhoid, okay, but we're going to talk about it.
Yeah.
But if it's weight loss, or you're suddenly anemic, or you're having chronic abdominal pain, and all that kind of comes in conjunction with bleeding, well, I think that's something that, will probably warrant a colonoscopy. So, in addition to talking about processed food, talking about fiber, talking about stopping smoking, limiting alcohol, and talking to your family about their history, be aware of your symptoms, look at the toilet paper, look at the stool, and kind of move from there. I see patients for all sorts of issues all day long. And with the advent of AI, okay, and we used to call it WebMD, we used to call it Dr. Google, and now it's, ChatGPT. Well, not everyone has access to up-to-date, but, ChatGPT, Claude, Google Gemini, whatever it is. I think one of the things that I would caution patients, and I tell my patients this, is, it is very easy to get yourself into a anxiety spiral about something you read online when you say, hey, AI, these are my symptoms. What's going on with me and what tests do I need? And I think, I don't know if you experience that in the ER nowadays, where I have patients come in and they have their phone ready out and they're like, well, this is what it says I have and this is what test it says I need. And some of that is right. Some of that is right. But I think it's important to, talk to someone who actually, did years and years of training in how to take the entire clinical scenario in your history, your labs, your symptoms, and not just a 1 or 2 sentence blurb that we're plugging into AI and is spitting out every diagnosis and every test under the sun, including some that are terrible but extraordinarily unlikely.
Yeah.
So I think that's one thing that I find I'm encountering more and more on a daily basis now, that I'm having to almost play therapist a little bit for some of my patients. From a GI treatment perspective, I also want to highlight that not everything requires a pill. Not everything requires a pill. There's a lot that can be done from holistic things, Okay, I'm a big proponent of gingers, peppermint oils, oregano oils, and there's a lot of good data behind this. There's a lot of great data behind hypnotherapies. There's a lot of great data behind meditation therapies. They're doing a lot of research nowadays with actually virtual reality therapy to kind of retrain the hyperactivity of the gut, so that when you're riding the subway and you feel that little urge that you need to go to the bathroom, you can say to yourself, no, I don't. No, I don't. And kind of calm it down, which actually makes a huge difference for people.
Interesting.
And so I think I have to find the right patient sometime who's open-minded to doing that, because some people come in and they just want a few tests and a pill, and
Right.
and they're not going to get past that. But I think it's important to consider all the kind of treatment options that exist out there when you're addressing GI health.
Yeah, that's a really good point. And I imagine that the cognitive behavioral parts probably take some time to really be able to like harness, but it makes sense back to the beginning of our discussion when we talked about the enteric nervous system, the just density of neurons that exist in our gut, and the role that the mind plays in our gut health and how interrelated they are. So I think that's actually a really great place to stop. So
Wonderful.
Thank you so much.
No,
Dr.
this was
McNeill.
great.
I feel like we covered a lot of topics.
Yeah. Get screened, everybody. Get screened.
Get screened
Yeah.
for colon cancer
Yeah.
when it's indicated.
Yeah.
All right. Well, thank you for joining me for Catalyst Chat.
Happy to be here.
Okay.
Yeah.
That's great.
Cool.